Let's begin Chapter 5. Its focus will be a family of disorders called the anxiety disorders, the specific disorder of OCD, in other words, obsessive compulsive disorder, and disorders related to OCD. We'll be discussing generalized anxiety disorder, phobias, both specific and agoraphobia, social anxiety disorder, which is often called social phobia, panic disorder, obsessive compulsive disorder. Now we could discuss separation anxiety and selective mutism in this chapter, but our focus of those disorders will be in Chapter 16 later in the course. And lastly, the OCD related disorders. A very interesting chapter. If you find yourself wondering, well, what exactly is an OCD related disorder? Good question. Hoarding you're probably familiar with, but perhaps not the term excoriation and or trichotillomania and or body dysmorphic disorder. So we'll be discussing all four of these OCD related disorders during this chapter. Let's start our exploration of the anxiety disorders with generalized anxiety disorder. Let's consider the diagnostic criteria. Excessive worrying and anxiety in multiple areas of life. So it can't be just one or two that you're worried about, English class and math class, or if you're worried about college and getting along with your suite mates. It's got to be in multiple life areas. Is free-floating, which means you really can't put your finger on why you're anxious, what's making you worry. So we use the term free-floating. Friends might call a person with generalized anxiety disorder a worrywart. Oh, you're such a worrywart, if you ever heard the term. It must cause significant stress or impairment to that person. And for diagnosis, it's got to be present for 6 months or longer. Issues would be in these three following areas: restless and or fatigue and or irritable and or muscle tension and or sleep issues and or poor concentration, and quite possibly most or all of these. Next, go ahead and click the link to learn a little bit more about this particular disorder. This slide is optional, so if you want to learn more about the perspectives and assumptions that go along with it, look at this slide. If you don't have a particularly strong interest in generalized anxiety disorder, you're perfectly free to skip the slide. So the socio and multicultural model, which emphasizes the importance of dangerous environments, dangerous socially, dangerous physically. The psychodynamic view emphasizes difficulties in controlling the id impulses, remember the sex and aggressive impulses, or in childhood relationships, such as the primary caretaker. Humanistics, non-acceptance of, three blanks, what could they be? If you're thinking, think, act, or feel, you are correct. Cognitive behavioral, looking at the basic irrational assumptions, such as everybody must like me, I must be perfect, I cannot make a mistake, and so on. And the assumption that worrying is a good thing. I should be worrying. It's a good thing to worry. It's constructive to worry. So that would be some of the things that the CBT people would emphasize. Biological, overactive fear circuit, and low GABA. Remember, the GABA is the inhibitory neurotransmitter. So short-term use of one particular family drugs or long-term use of another family, take a moment and see if you might want to guess. So short-term use of the anti-anxiety drugs such as Valium, Librium, or the old barbiturates, hopefully not, or long-term use of the antidepressants. This slide is hopefully somewhat review, seeing if you remember and have learned the basic approaches. In this example, tweaked to generalized generalized anxiety disorder and the other anxiety disorders, yes, but what applies for this is just the basic overlying assumptions of the model. So try to do it by yourself and then go ahead and look at the answers. In the secondary narration, it mentions optional. I have changes to a required knowledge as reflected in the slide. So give it a go. So like the other side, this slide is too optional. Though if you're interested in the mental health professions or social work, this might be one that you really would want to do. So the sociocultural and multicultural perspective have no specific tools. Psychodynamic, all the different tools get at what part of the mind? Hopefully you're thinking unconscious. Humanistic, emphasis of unconditional positive regard as a tool. Cognitive behavioral, rational emotive therapy, or mindfulness CBT. And as we noted on the previous slides, a biological, originally looking at the barbiturates and the more modern benzodiazepines, more modern, likely to use the antidepressants. So now let's consider the phobias. To be a phobia, it's got to be intense, and it must be irrational. If it's not intense, it's not a phobia. If it's not an irrational, it's not a phobia. It can be of an object or a particular type of situation. They will cause significant stress or impairment, and often in the terms of avoidance. The symptoms must be present 6 months or longer, and it's often regarded as the most common mental illness. Let's consider the categories of simple phobias and agoraphobias. Now, often textbooks will put social phobia, also known as social anxiety disorder, in this family also. Your text treats it as a separate category. It's fine either way, as long as you understand the specific disorders. Simple phobias, I often get the class to share. Phobias have lost their stigma, which is fabulous. So simple might be of animals such as dogs or cats or birds. Perhaps such things as needles or blood. Perhaps more unusual things such as lint or holes or styrofoam. Agoraphobia. Well, an agora, I was lucky enough to go to Agora when I traveled Europe. An agora in Greece is a marketplace. So literally, fear of the marketplace. Now, it doesn't have to be literally a marketplace. It's fear of leaving one's safety zone, which might be one's home, one's street, one's neighborhood, and often involves situations that you cannot extract yourself out of quickly, such as a classroom, a supermarket. Now, as mentioned, social phobia or social anxiety disorder, the nature of that fear is negative evaluation, concern with perhaps a negative judgment. As noted on the previous slide, social anxiety disorder is also known as social phobias. To be present for diagnosis, it must be there 6 months or longer and cause significant distress or impairment. The essence of it is fear of being and somehow negatively evaluated. That person isn't smart, that person's clumsy, that person's not competent, that person's not pretty enough or strong enough or what have you, or talented enough. Intense fear of being negatively evaluated. Often enhancement of self-esteem is useful, skills training, and an examination of irrational belief systems. Let's consider treatment for phobias. CBT therapy is particularly useful. Exposure-related treatments, such as counter-conditioning, in which, for example, the Peter and the Rabbit scenario mentioned earlier in the course, where a calming stimulus is put in pairing with the scary stimulus in a skillful manner. Desensitization can either be done systematically or real life, or flooding, throwing the person into their worst fear. For agoraphobia and social phobia, reducing fears and skills training. For all three, dialectical therapy can be very useful so they can tolerate and regulate emotions related to that phobia. Let's continue our discussion of the anxiety disorders, focusing on panic disorder. With this diagnosis, the person has to have repeated panic attacks. So having one panic attack does not mean panic disorder. I should mention that almost half of college students will have, sooner or later, a panic attack. Very few develop into panic disorder. So hopefully that calms your mind if you've had your panic attack. The symptoms must be present for diagnosis 1 month or longer. They must cause significant distress or impairment. In class, we'll look at symptoms of the attack. So often the heart is racing, so it can be easily confused with a heart attack. Respiration often becomes very rapid. And if you hyperventilate, that causes a whole host of things to happen, such as numbness or tingling. It can also, that hyperventilation can affect your vision. And vision varies quite a bit. Some people say blurred vision, or tunnel vision, or black and white vision. The person will often become very sweaty. The person might feel lightheaded. Emotionally, some people describe it as the most fear they've ever experienced, or a feeling of impending doom or death. So it can be very severe. When it passes, the person typically feels emotionally and physically drained. Now, sometimes panic disorder will develop into agoraphobia. The person starts to avoid the places they've had panic attacks. So a very high percentage of people with agoraphobia have panic disorder too. A fairly low people with panic disorder have agoraphobia because, again, it does not necessarily or even typically develop into agoraphobia. But this is another reason why this disorder should be treated so it doesn't morph into another condition. Common treatment options include antidepressant prescription, as well as CBT therapy. For example, people with panic disorder often incorrectly interpret body sensations. They think that this is abnormal or that it necessarily must lead to a panic disorder. Not at all the case. So reassessment of normal body sensations. Now please go ahead and click the link for panic disorder. Let's now consider separation anxiety disorder. In previous DSMs, it was limited to children, which is no longer the case, though the nature of the fear differs from children and adults. It always involves intense anxiety when separated from loved ones. In adults, the fear often includes the other person's safety. Would they get into a car accident? Would they be assaulted by a criminal? Or so on. It has to be present for 6 months in diagnosis in adults, but merely 4 weeks in children. For both, it often involves sleep issues, refusal to leave the home, and many physical symptoms. And it will always cause significant distress or impairment. Recent DSMs have linked anxiety and OCD-related disorders, so let's continue our discussion of anxiety and the OCD-related family. We'll consider OCD on a future slide, as well as hoarding, excoriation, trichotillomania, body dysmorphic disorder, and later on in the course we'll discuss selective mutism. This is in children when they refuse to speak around some people, it is an anxiety condition. So you see I can obscure the O and the C in terms of what it stands for, as well as on the definition of each of those two terms. So think a moment and see if you are familiar with OCD and what the first two letters stand for. Go ahead and actually do it. Okay, so the O, if you're thinking obsession, absolutely. And C, is that convulsion or compulsion? Well, it's obsessive compulsive, so compulsive disorder. Obsessions are repeating thoughts which cause the person great anxiety. Then what's a compulsion? The compulsion is behavior. So obsession thought, compulsion behavior, a behavior one feels compelled to do. You should note that in OCD, obsessions are a must. Compulsions are typically present, but not always. For this diagnosis, there must be significant distress or impairment. Impairment can often include excessive time spent on the compulsion, for example, an hour or more, or a lot more per day. The attempted suicide rate in this condition is fairly high, 25%. So not only does it significantly impair the quality of life, it puts one's life at risk. So again, treatment is a must. There are common themes such as contamination. So for example, the picture is showing the compulsive behaviors of hand washing and scrubbing. Taboo thoughts in terms of maybe harming somebody, doing something unacceptable, such as getting undressed or yelling obscenities in an environment that would be particularly inappropriate. Harm. So thinking about harm that might come to an individual, or you actually committing harm to somebody. Or the themes of things need to be perfectly organized, hence the picture with the paper clips. Many times the compulsion and thoughts will involve ritualistic thoughts, hence the picture on the left of the person flicking the light switch. So the obsession, the thought of doing it, the compulsion if they do, the behavior of flicking the light switch. Now go ahead and view the links to learn more about this particular disorder. Next, let's consider body dysmorphic disorder. It joined the anxiety and related disorder category only in DSM-5. A person with this disorder is preoccupied with perceived flaws. They can be a very minor flaw that most people would not even notice, or quite possibly not there at all. So a person might think that their nose is excessive, and they might refuse to date because they find themselves so unattractive. They might refuse to have children because they're afraid they'll pass on their terrible nose. Or their nose might be perfectly average, maybe slightly large, but it looks very good with their face. So again, minor defect or non-existent defect becomes overwhelming. There's often repetitive behaviors related to this perceived defect. Checking it constantly, grooming, hiding it, seeking reassurance from others. It must cause significant distress or impairment. The person is likely to have poor social functioning, so that could be addressed quite easily in therapy. Sometimes so severe that hospitalization is needed. The picture below, I assume you recognize Michael Jackson as a child, with very different facial features as an adult. And there is considerable discussion and the view typically that Michael Jackson did seek multiple surgeries because of body dysmorphic disorder. Obviously, surgery is never enough because the flaw is still perceived. Next, go ahead and click the link to learn more about this disorder. Now let's consider the disorders of excoriation and trichotillomania. Trichotillomania is all one word. I just broke it apart since it's a lot of letters. It's maybe easy for you to perceive and read it. If you're not familiar with either one of these two disorders, don't feel bad. Excoriation refers to picking at the skin, and it will be to the extent that it causes lesions. The person cannot stop doing it. They often believe that there's itching going on or something physical that causes it. They'll often seek help from a dermatologist who usually can identify by the nature of the lesions that it was caused by the person and not by a medical issue. It often comes and goes, particularly in times of high stress. The person goes at their skin more as a stress-reducing mechanism. It must cause significant distress or impairment or damage, as in the nature of the skin itself. But go ahead and click the link. Let's next consider trichotillomania. What's the key feature hidden by the title? If you're thinking the pulling out of one's hair, absolutely. The person pulls out the hair. What do they do with it? They do not inevitably, and this is a little bit unpleasant, they do not inevitably consume it, in other words, eat it. That is particularly dangerous. It can build up in the stomach, causing death or the need for surgery. Sometimes they'll just let it drop to the floor, flush it down a toilet, drop it out a window, throw it in the garbage, what have you. But they pull out their hair. It can be singly or by the clump. It can be from the head or eyebrows or eyelashes or really anywhere in the body. And again, the person cannot stop doing it. For diagnosis, it must cause significant distress or impairment or damage. Go ahead and click the link. Let's now consider hoarding disorder. It can be of objects or even living animals. You probably hear every year in the news several times in which a massive hoard of animals has been seized by an animal shelter. Many times there are dead animals on the scene. Many times they're locked in cages with inches of feces. Many times there's dead dogs in these horrible cages, dead from the conditions. People with a disorder vary drastically in terms of insight. Sometimes they say, I know it's disgusting, I know it's terrible, I know I'm sick, but I can't help myself. Other people just say it's a little crowded, or I've got a lot of animals. So they differ dramatically in terms of how they can see their condition, in terms of accuracy. It's a severe health risk for them. It's a severe health risk for any animals or people in the house. By definition criteria, it's got to cause significant distress or impairment. It can also be a threat to even one's neighbors in terms of disease, rodents, and other life forms sharing the house with them. I've seen a fire in this house or a house that the person would never be able to get out in time. So go ahead now and click the link to learn more about this disorder. So let's briefly consider some treatment options. For all these conditions, increase in regular exercise can be helpful in terms of lowering anxiety. The teaching of relaxation techniques also help to serve a similar goal. In terms of CBT, mindfulness is particularly useful. For phobias, techniques that we mentioned earlier in the course, such as flooding, systematic desensitization, modeling, counter-conditioning, and the use of virtual reality exposure are all highly useful. For OCD, thought stopping. Every time the person thinks of the thought, they must tell themselves silently, stop. They think it again, they tell themselves silently, stop. And it helps them to break the cycle of thinking about that thought or thought and behavior. Response prevention. So if they desperately want to wash their hands 30 times, they have to maybe wait 30 seconds, then we'll up to 1 minute, then we'll up to 2 minutes. So preventing the response involved in the OCD pattern. For generalized anxiety disorder and social phobias, a critical component is to address the person's maladaptive and irrational thinking, such as, it is useful to worry, I should be worrying, and so on. Let's continue and look at biological treatment, starting with the anti-anxiety drugs. Hopefully you remember from earlier in the course that The anti-anxiety drugs, such as the old barbiturates, or the slightly newer and slightly less problematic benzodiazepines, such as Valium and Xanax, have significant concerns in regards to their use. Overdose, especially when combined with depressant drugs such as alcohol, that they're addictive, that they can often cause sleep issues. And they are definitely not meant for long-term use, typically use of days or a few weeks, not typically for months or even years. It is more common now to use antidepressants. You might ask, well, when do we want to use the barbiturates? Often short-term while the person's undergoing therapy in order to give the therapy enough time to become effective. That's one of the most useful applications. Antidepressant drugs. Some antidepressants increase anxiety, some decrease it. So obviously the physician or mental health professional must choose wisely. And if you're seeking help for just depression, but you have some anxiety symptoms, it's good to mention to your treating professional that you have anxiety too, and certainly don't want a drug that would make your anxiety worse. Antidepressants, unlike the barbiturates and the benzodiazepines, are very safe for long-term use. And with that, we've completed this chapter. So let's go on to our next chapter when you're ready.